Good afternoon and welcome, everyone. Thank you for joining us for this special hour-long webinar. I am Pia Pine-Miller, the Senior Director of Strategy and Business Development at the Gold Foundation. We are excited to be collaborating with mindful practice instructors, Drs. Mick Krasner and Ron Epstein, on their programs and workshops. Part of our ongoing work to promote practitioner well-being and humanistic care. These transformative and thriving workshops are based around 4 elements: finding meaning, feeling part of a community, riding the waves with aplomb, and changing the work environment. Dr. Mick Krasner, along with his colleague, Dr. Ron Epstein, have truly been leaders in the field in so many ways, and a few of which I'll share briefly. We're also so thrilled to have so many partners, colleagues, and institutions with the Gold Foundation from all over joining us for this Flourishing at Work Overview Workshop webinar today, who all clearly value practitioner well-being. A few notes on Mick. He is joining us today from the University of Rochester School of Medicine and Dentistry, and he is a professor of clinical medicine there, and with Ron is the co-director Mindful Practice Programs. He has been teaching mindfulness-based stress reduction for more than 18 years, involving several thousand participants and over 1,000 health professionals. He is engaged in a variety of research projects, including the effects of mindfulness practices on the immune system, in the elderly, on chronic psoriasis with caregivers of Alzheimer's patients, and on medical student stress and well-being. Mick is a world-class leader in this important work, especially from a healthcare perspective, working with physicians and other healthcare professionals around the globe. The Gold Foundation was an early supporter of Mick and Ron's work, and we began collaborating in partnership around the program last year. We're proud to be able to facilitate access to these engaging, interactive workshops for all our partners. At this time, I'll turn it over to Mick.
Thank you, Pia. It's a pleasure to be here on this lovely day, and I hope you're all having a nice day so far. It is lovely here in Rochester. Uncharacteristically, it would be typically like this picture that you should be seeing here. That's a little bit more common from a March 4th here. So I'm really excited. I'm really grateful to the Gold Foundation for the support they've provided, and also for their interest in collaborating with our mindful practice programs. And I hope during the presentation here, if you have questions, that you open up the chat and send a chat to everyone, or just to my name on it. And at the end, when we'll have some time to I'll have some time to respond, I will try to get through those questions. So enjoy and see what it's like to, in some ways, passively listen, but also be engaged at the same time. That's a lot of what our work is about: engagement, observing, noticing, and being in relationship. My subtitle for the talk today is Everyone Complains About the Weather, but Nobody Does Anything About It. This was attributed to Mark Twain, although he did not really say it. There actually is something we can do about this climate that we live within in medicine. Not only that we can do, but our leaders can do and our institutions can do. And it really requires a collaboration such as the one we have now with Gold to help bring about the kind of changes that could improve our flourishing in work, which is intimately connected with the quality of care that we deliver. And I'll say more about that. So we'll just forge ahead here. It's no surprise to any of you who are engaged in healthcare or engaged in just caring for anyone that we are in somewhat of a crisis. There's, from a clinician's perspective, perhaps a manager and institutional leader as well, that we often are facing questions about how do we derive the meaning out of our work? Who are we? What is our purpose? And what is our role? What are we doing? What is our true role? And we can look back on where we've come from as a sort of a guideline to understand what it is that perhaps we may have lost along the way, and how it is we can rekindle and reestablish our relationship with that which we hold most important, which brings us meaning, which gives us a sense of professional identity, which underscores our purpose and really solidifies our role in the healthcare work that we do. This is a painting. I took this photograph at the Tate Gallery in London. Luke Fields was asked by Tate himself to create a painting of social importance. He was commissioned to do this. This was in the 1860s. Luke Fields had undergone a loss of one of his children, a son, at age 9 to an illness. And he was so taken by the sense of presence of this physician who sat vigil at the bedside of this ill child, or his child's bedside, that he thought this was a socially important figure within the context of that culture at the time. You can see in the right-hand side of the painting the mother who has her head in grief, held by her hands. The father is placing an arm of comfort upon the mother's shoulder, and then the physician, who couldn't do much in terms of intervention at the time, pre-antibiotic era, but clearly understood what it was to observe, to watch, to look for signs, and to be present. We'll say more about that presence, because that is one of the key qualities of mindful clinicians. In the conventions of painting of the time, this painting was supposed to depict a positive, optimistic outcome, with the morning light coming in from the window along with the lamp illuminating the child's face. Now, if we just fast forward to not that long ago, 10 years or so ago, we see a different kind of art piece. This was a colleague of mine's, a patient in her clinic. She was a med-peds trainee with me in Rochester, and she now teaches at Brown University. And in her clinic, one of the children brought this in as my visit to the doctor, a very healthy appearing 7-year-old who places herself at the center of the crayon drawing, appropriately so. And you can see maybe a mother, maybe another sibling holding a younger baby. And then where's the doctor? What's the physician doing? What does this say about the normative experience that our patients have, a well-adjusted, healthy appearing child has in the medical encounter? I think this speaks volumes about some of the issues and the crisis that I pointed to earlier. The title of this editorial, which appeared in the Journal of the American Medical Association, was called "The Cost of Technology." Now, this technology is phenomenal, and it helps us in so many ways, but that's one of many things that we have to learn to work with and not lose our sense of purpose, role, identity, and meaning along the way. So I just want to pose to you a hypothesis. If we look at the natural world, we can see that, there's dry conditions, there's moist conditions out in the ocean, there's dying, there's living, there's a whole host of environmental and ecological relationships with our environment that ask us and that have actually helped us evolve to become resilient. Uh, we're actually uniquely designed to be resilient and to flourish. We have evolved to do so. We are survivors, if you will, of a long multi-generation heritage of survivors before us. And because we are designed for this, we should look upon how is it that we manage stress? How is it that we manage these challenges, which actually are so important to the diversity that we are and the diversity that we see in the natural world, but so important to us in terms of our professional work, meeting challenges that our patients present with. It does involve reimagining how we relate to the stresses that we experience. And that involves, interestingly enough, appraisal and resources. And what I mean by that is that one of the definitions of stress is that stress is experienced when one appraises or perceives an experience or situation as taxing or exceeding our resources. So what does that mean? How can we actually have any impact on the stress that comes at us that we engage with? Well, one way is to really looking at how we see it, how we appraise it, and then the other is building resources to manage it. And I'll say more about that as we move along. It involves acquiring certain skills and knowledge. One of the resources we have is our intellect and our cognitive capacities and the tremendous training that we've undergone in order to become health professionals. There are other skills that have to do with observation, have to do with self-awareness and self-assessment, as well as assessment of the interpersonal space between us as we engage with other human beings. And it's not easy. It requires a long practice, a long training. You know, Hippocrates famously said, ars longa. The art of medicine is a lifelong art to never to perfect, but to continually practice. Requires a commitment, which I'll say more about, to self-care. Interestingly enough, has a direct impact on our ability to deliver quality of care to others. And because we live in a world in which the arc from, let's say, birth to end of life, that arc is heading in that direction continuously, it's imperfect. People become ill. Mistakes are made. The systems that we work within are far from perfect. So we have to learn and train ourselves to experience the micro failures and work with them in a way that we learn and build that resilience. Another beautiful way of describing that resilience was put together by Jane Hirschfield, who says that she's come to admire resilience, not the simple act of a pillow whose foam returns over and over to the same shape, but the sinuous tenacity of a tree. Finding the light newly blocked on one side, it turns in another. A blind intelligence, true, but out of such persistence arose turtles, rivers, mitochondria, figs, all this resinous, unretractable earth. So this photograph, I should mention, I went to medical school at the campus of University of California in San Diego. This is taken there. This is a Torrey pine. And the Torrey pine exists only there, and only exists there because of its interaction with its environment and how it has been shaped by its environment, having its genetic endowment to include this ability to change and alter and bounce back and be newly shaped again by the trials of living like us. If it wasn't for this capacity, and if it wasn't for the stresses that we face in our lives, we wouldn't see this great beauty and diversity in the natural world. And if we were to display everyone on this call, there would be differences of gender and age and race and whatnot, all this diversity really out of our interaction with our environment and how our genetic endowment works with that. Let's talk about appraisal, how we see a situation. We know that patients experience, two patients with the same illness have a completely different, naturally, medical illness experience depending on many, many, many factors. When we observe a situation, when we encounter something that's quite challenging to us, one of the areas in which we can work at, especially as we cultivate this capacity to be mindful, which I'll say more about in a while, is how we perceive, how we look, how we observe, how we appraise. I took these photographs in South Africa at a museum, and they're beautiful ceramic colored round things, I guess you could call them. And just watch what happens as we take a different perspective. We begin to pull back and look at the larger view. And often in medicine, we're very up close. And we also want to look at the big view, the biopsychosocial view. Suddenly it takes the form and shape of a face of a human being. So looking at the large view, looking at the close-in view, and in between. And then there's resources. I mentioned that stress being experienced as that experience in which we appraise a situation taxing or exceeding our resources. This I took this is the Sawtooth Mountains in Idaho. Was doing a workshop for an Idaho osteopathy program conference. And it just reminded me that we have tremendous resources. And as I mentioned before, the resources that we have built through years of study, the resources that we have built through years of experience in our clinical work, and the resources that we can continue to build and cultivate through cultivating this capacity to be mindful, to actually bring awareness to the actuality of our experience in the now, the internal experience, the feelings, thoughts, and sensations, as well as the external experience, what we're seeing and noticing around us. And if we can do that clearly, initially with observational skills, then the interpretation, the diagnoses, and what we understand to make sense is likely to be more accurate than if we just automatically, without awareness of all those factors, come to conclusions, sometimes too early. So this is just a check on myself to let me look at the watch for a moment, just so I can calibrate my own speaking speed and make sure we're on track and that I'm on track. I tend to just begin and talking. So also this gives you an opportunity, if you're thinking of any questions that arise, jot them down or open the chat, stick them in the chat, and we'll see them at the end as I move on. So one might ask, why should people, the general public, let's say, really care whether we're in distress as clinicians, whether we're in that crisis that I described in medicine? Well, I'll make, I think, a very cogent argument why it matters. It turns out that our well-being is very intimately connected. This is actually beyond argument at this point in terms of the empirical research to support this, that our distress leads to poor quality of care. On this slide, you can see a list of a number of things that have been documented in the medical literature and studied to be true in terms of our distress. That connection between our resilience and the quality of care, or if we flip it upside down, if we are burnt out or not well, the actual error rate, the mistake, the poor quality of care that results is very, very much agreed upon now. I think, as I said, it's beyond question. If we look at this third part of this slide, you'll see quality of caring. And for those of you who are actually practicing medicine in an environment in which your revenues are dictated by multiple factors, not just say a fee for service, most of us have a growing degree of our work being reimbursed by other metrics, including, however imperfect it may be, some measurement of quality of caring, some measurement of the patient experience, Imperfect, yes, but clearly is part of what we all experience when we become patients, or when we are patients, because we all are, that quality of caring, and that our resilience, our well-being is also connected to that patient experience. This, I think, has face validity to it. I think it's hard to argue that. And I'm going to argue and show you our model for, later in the presentation of how we can bring these pieces together through this program we call Mindful Practice. I did want to say a few things about burnout, and I don't want to really spend too much time in making this talk about burnout because it's been in the literature. Many of us have to take a well-being survey annually as part of our institutional responsibilities, and we're almost being burnt out by burnout itself. But I wanted to give you a little sense of how burnout is measured. These three domains are from the most common metric that measures burnout, called the Maslow Burnout Inventory. Christine Maslow is a sociologist at University of California at Berkeley, and she studying human services workers and looked at, in particular in medicine and health professionals, burnout, and came up with this structure, this way of looking at it that really divides burnout into these three components. And most of us can relate at times to being connected or being burnt out in some way, even however briefly, feeling emotionally exhausted. Certainly our long work hours sometimes, or actually the emotional content of the work can lead to a condition in which we experience this. Depersonalization, I should say a little bit more about that. So that's a situation in which we begin to, through our stress, we begin to treat other human beings, sometimes our patients even, sometimes the workers around us, our staff, sometimes our colleagues, sometimes our loved ones at home, in an objective way, in a way that objectifies them is what I mean to say, depersonalizing them. And, you know, there are moments in all of our lives in which that happens when the situation is such that, and then we look back and feel bad about that. And then the third component is this low sense of personal accomplishment. Completing our workday, completing our work week, looking back on months of our career or even longer epochs of our career, and having this sense of, you know, what's the meaning and purpose of my work? You know, who am I in it? Does it help anyone? Actually, this low sense of personal accomplishments, which can be one of the most discouraging parts of the burnout equation. Burnout has been measured using this inventory as well as other scales for now a few decades, and there appeared to be a very sharp rising trend over the last 20 years, perhaps tapering off in the last half a dozen years. It affects a lot of, depending on what your cutoff is, a lot of physicians and other health professionals. Nursing profession is at high risk. And it turns out that among the highest risk are those parts of the medical profession that are at the front line of medicine, primary care, emergency medicine. They have seemed to be among the highest at risk for this burnout. It starts early. We begin to see it early in medical education. And looking at practicing physicians, that there was actually a fairly significant rise between 2011 and 2014. The same group from the Mayo Clinic reported recently in 2019, published on their data from 2014 to 2017, that there had actually been some improvement, perhaps because of a recognition of this phenomena and what it's actually costing institutions. I'll say more about that. What causes it? You know, the causes, we can point to so many causes. Some of them, the external environment, the work environment, the way the work is set up. I like to joke in a certain way that if I'm doing a presentation, if I want to suck the air out of a room very quickly, all I have to do is say 3 letters, EHR or EMR. And so that's an easy one to point at because of how it has created in some ways a lot of extra work, and I'll show you that. But there's psychological factors, physical factors, and we talk about balance. I don't particularly like that construct of a work-life balance, as if work is not your life. In fact, we've sacrificed and done so much in order to create a work life, to be a professional. So to balance work over life seems a very odd construct to me, and I'll say a little bit more about that. This is just an example, a very disturbing example, that if you look at medical students when they enter medical school, this shows mental health self-ratings, but if you look at physical self-ratings as well, they are actually quite resilient, quite healthy, in fact, healthier than their peers. And then at the end of the 4 years, if you do the same analysis, you find that they're worse off in most measures of psychological well-being, physical well-being. If this isn't an indictment to something that's going on in the culture of medicine itself, then I don't know what is. And it's clearly something that has grabbed a lot of people's attention, especially as we understand the connection between quality of care and our well-being. So I've been really lucky to live in the community where Ron Epstein lives, who really began talking about something called mindful practice now 21 years ago, writing about it, and then working together with him to create interventions that could help us. And we really, he and I have spent a lot of time talking about what does it mean to be resilient, and I think related to that poem that I shared with you, the picture of the Torrey pine, and the hypotheses I posed, that resilience is not just this ability to bounce back, but actually to grow and to flourish. And we're moving away personally from talking about resilience itself and talking about burnout so much as we are talking about flourishing. We really feel the money is on how do we create, what can we do to help in our institutions and our organizations, and personally, what can I do, what can you do to help improve and enhance our flourishing in our profession, our professional flourishing. This is a really interesting concept here, but if we think about the things that we hold to be very true and very important in our medical work, the positive values that we place on being service-oriented, having excellence, medical excellence in the work we do, being competent and knowledgeable, certainly being empathic and caring, and having equanimity, which is sort of this ability not to be a little unflappable, you know, facing situations without being so emotionally rattled by them or physically rattled by them. That every one of these qualities that we would all agree upon are important in our work has a dark side if taken to an extreme. So that if we are so focused and cannot live without excellence, it feeds our perfectionistic tendencies, which we all have, especially in medicine. Knowledge, this need to have knowledge, we almost become unable to make decisions because we have to be so certain if we take it to an extreme. Empathy is a real interesting one. If you think about that word, empathos, in the passion, in the pathology, in the suffering, actually feeling what other people feel. It turns out there's some evidence that shows that as we score higher, let's say, on scales of empathy, we are at higher risk for burnout. we actually can experience personal distress. So that's a really interesting question. We want to be empathic, but it actually can do us harm. How do we shift that relationship so it isn't? And people talk about a shift to something that's a little more compassionate based, compassion with passion, with pathos, with the suffering, that we can stand alongside and work with it. There's a lot more I could say on this subject because I'm very interested in the differences between compassion and empathy. So anyway, needless to say, resilience, flourishing may look differently. It's reframing, again, reappraisal, as we talked about earlier, having a sense of one's own limitations, becoming comfortable with uncertainty, taking compassionate action rather than feeling everything that our patients feel in terms of the suffering dimension, and taking care of ourselves. You may recognize this. So this is taken from the American side, not far from here of the Niagara Falls, just on the edge of the Niagara River as you look north, and you see the American Falls here on our left, and then the Horseshoe Falls, the Canadian Falls, as it is spoken about straight ahead. How can we enter these turbulent waters without being overwhelmed? How can we address this without really feeling like we're going to drown? And just share with you this cartoon. Sometimes this is the most compassionate response, this kind of help that we can have. I highly recommend it for myself often. Sometimes just talking it through seems to help. But I would argue, and our program asks participants, and our participants show up and do this, is to move in closer. Really take a really close, hard look at what it is that is causing our distress. And I'll say a little bit more about how we take a look at this distress component in what's called an appreciative manner. And that, I think, is one of the keys to our program, which I'd like you to leave with having an understanding of that. Just some pieces of not random, but related information I think is helpful so we can have this conversation. The first, these have to do with some of the studies that are showing the source of our stress. The physician time allocation, for every hour that we have clinical face time, there's about 2 hours of work that needs to be done. That if you look at the usages of the electronic health record and you look at the time of day it's being used, evenings, Friday evening, there's a peak of usage in the electronic health record. This is your, what has been called Saturday night, date night. This is what you're doing at home with your loved ones, spending a few hours doing your charts. The moral injury that occurs when we have situations that we are impotent to make good decisions because of technical factors, because of economic factors, because of healthcare system factors. That's called moral injury. That it turns out that, interestingly, people, and many of us are this way, that have identified medicine as a calling are at slightly higher risk for burnout. The connection there, it's interesting. I think it needs to be teased through a little bit. Regulation and requirements, in some ways, in some studies, are showing more than the electronic health record seem to be related to the burnout rate. And I do not think balance is an adequate word. Self-care is important, whether we're at work, whether at home, just in general. That burnout has a huge effect on the viability, the financial viability of healthcare institutions. It's only beginning to be recognized. And it's an interesting thing to think about. What would it mean to use our health professional burnout as an indicator of how healthy the health system is? And this has been placed into a charter on physician well-being, that this is something that's very important. So I wanted to walk through the literature a little bit in a fairly rapid way with you, and then tell you about our program. In 2009, Michael Kearney, who's a palliative care physician, originally from Ireland and worked in Montreal and now is in California, talked about how to help the people who are giving healthcare, the professionals. And this was really an exposition on what can be done. And he talked about self-awareness skills and communication skills and sustainable workload and mindfulness and supervision and mentoring. It's interesting, in our work, we don't have a mentor supervision model in the physician side of the healthcare professions that they do in the behavioral health side. And I think it would be something to rethink. Colin West at the Mayo Clinic looked at a large review of several thousand studies and found about 50 or so that met the criteria of what could help burnout, involving nearly 3,000 physicians, and showed there were actually a number of interventions that improved those domains of burnout: emotional exhaustion, depersonalization, and a low sense of personal accomplishment. Some of them were individual focused. Some of them were organizational strategies, and I'll mention at least one of them. A much larger, a very large review published a year or two ago that culled a lot of literature into just a few articles that were very well done. Articles on interventions show that it seemed that mindfulness, team-based communication skills, and leadership interventions seemed to help. They recommended multiple different strategies. And this just makes sense. Every community is unique in their own stress experience and what the pain points are. And so we should be thinking of developing a variety of interventions that could help. This was just published in Medical Education. Ron Epstein is one of the authors of this review, looking at mindfulness-based interventions involving physicians. Interestingly, there's been a lot of them, but they reviewed 24 that met their criteria, and it turned out that in their review that physicians themselves perceived these interventions to be quite beneficial on their well-being and also on their performance as physicians, and that health organizations should consider group-based mindfulness interventions. And I'll talk about ours in a moment. Back to Mayo, they did a very simple intervention where they took Department of Medicine faculty and gave them protected time for an hour every other week for 19 sessions. Very loosely structured. There's discussion and some small structure around what they would do in these meetings where they didn't have any other responsibilities, and they showed improvements in work engagement, empowerment, and in burnout, and meaning at work increased. So this is an organizational strategy that seemed to help build community and hold that thought, because our research has also supported that sense of community. We took our mindful practice program, which I'll describe to you in a moment, and we studied a year-long training program using mindful practice and looked at it with 70 primary care physicians over the course of the year, and our findings will follow. We have embedded these interventions, these programs now into postgraduate education, which is a lot of the time we spend doing in residency education, even in third-year medical student education. Our model, our hypothesis, looks like this. You saw earlier this connection between well-being and quality of care and quality of caring, that mindful practice brings this together. So I want to talk a little bit about what is mindful practice. There's 3 components to it. There's the cultivation of mindfulness, word that's being used so commonly. People are now jokingly referring to it as Mick mindfulness, like McDonald's, that it's just in our lexicon and we don't really know what it means. But originally, John Kabat-Zinn at the University of Massachusetts talked about awareness by paying attention intentionally, on purpose, now. And it's important, especially in our medical work, in the present moment, without judgment. Right? Impossible. But actually an awareness of the judgment that we have. And so that's mindfulness. The way to cultivate it is through contemplative practices, interpersonal dialogue practices, where we really focus on our ability to be aware of what's actually happening. We use appreciative inquiry. I mentioned that earlier, you may have caught that This is a change management approach that focuses on strengths and capacities rather than problems. If you look at our electronic health record again, we have a problem list, but we don't have a capacity list on it, a strength list. But that's actually what we're asking our patients to leverage in their work to manage their conditions. And it's actually what we leverage in our work every day. The things that we do and know we do and can use successfully. And so our program uses ideas and things from appreciative inquiry, which I'll say more in a moment. And then the third component of our mindful practice program comes from narrative medicine. It's really looking at the stories we have in our life. It turns out that some studies have shown that really reflecting on the work we've done in a narrative fashion actually can bring us a sense of meaning. So what we ask participants to do in our program, which originally was a year long, but now is in multiple different ways of delivering it, in particular 4 and 5 day intensives and 2-day intensives and webinar intensives, is using, looking at themes. We have modules. The themes may be something like suffering, or errors in medicine, or grief at work, or teamwork. All these themes we explore using contemplative practices and some didactic sharing of the literature. And then we ask participants to share experiences they've had related to those themes, suffering. When have you worked with a patient, talk about, share a story about a patient that was having a lot of suffering that you were working with, and how did you manage that? We flip the question so that we're looking at how did we get through that? What were the strengths? What were the capacities we had to address those questions? So that's sort of the basic program. And we studied this, and we published our results in JAMA about 10 years ago, that actually participation in this program improved burnout, improved patient-centered activities, empathy, psychosocial orientation, personality, which we were looking at personality as maybe some people with certain personality types do better than others. We actually saw changes in personality structure, which is felt to be sort of trait by the time you're, these were physicians' average length in practice was about 15 to 16 years. Increased emotional stability, one of 2 improvements, changes in their personality. That these associations were mediated by improvements in mindfulness, their mindfulness scales. And when we went back and did another study, a qualitative study, asking the participants what was important to them, they identified 3 themes. And they were the following: community. One of the things that we are terribly impoverished nowadays in our profession is this sense of community, fragmented workplaces, spending much of our time, as I showed you earlier, doing our computer work, charting work, and little time interacting with our colleagues in what turns out to be meaningful ways, even if it's a social interaction. Skills development, the narrative skills, the skills of cultivating mindfulness, was the second of 3 themes. Then the third theme I would like to share with you, I think, is the most telling. This is an awareness of the difficulty we have, this group had, the 70 group, this group of 70 primary care physicians had to give themselves permission for self-care, for self-development. That even with the improvements that we were able to show, there was still this sense of it's taking time away from what I otherwise should be doing. And I think we'd like to see a shift to actually what we all should be doing, but would love to be doing, is things that improve our self-care and at the same time improve our ability to care for others, that quality of care. So just to summarize, I didn't talk too much about urgency, but there is, I think, an imperative. I think we're reaching this crisis of burnout in a way that's really costing ourselves dearly in terms of our professional satisfaction, but costing our systems dearly. It looks like burnout, some conservative measures, estimates rather, suggest in the US is costing the healthcare industry over $4 billion a year. That it can't be just an individual problem, that it's not my problem as an individual, that I'm not resilient enough, or that I'm need remedial help. That's the wrong message, and it's not the accurate message. We actually are incredibly resilient. We've been chosen because of our resilience, as I showed you how medical students start out, and that it takes both individual and institutional collaboration and commitments. And that part of it is that starting close in, turning toward those pain points and actually exploring them through awareness and through the stories that show us that we actually have more capacity than we thought we had. And learning to work with uncertainty, and that this isn't a remedial program. This isn't for just the at-risk or those who are floundering. This is actually basic. This is actually primary skills to be a good clinician and a health professional. The skills of observation, the skills of awareness of how our judgments can interfere with our clear seeing, the skills of simply being present, as in that original painting called The Doctor by Luke Fields. I'll leave you with one more thing, and then I'm going to open up and answer, there's at least one possible question in the chat. I'll open it up in a second. I did want to say the following, that we are so thrilled and excited to be working with the Mindful Practice program through the Arnold Gold Foundation, that if you have any questions and want to explore options, possibilities of bringing this kind of work into your community, then please call Pia Miller at the email, which is pmiller@gold-foundation.org. She's lovely to speak with. She knows our work very well. The Gold Foundation staff has all been involved in some training with mindful practice, so they really understand it from the inside, and I think they'll be a very good resource. And you just say the word and ask, and Ron and I are happy to also talk directly with you. We're happy to do so and answer any questions you might have. So I'm going to try to open up this chat. It says one in chat from Jeff to all the panelists, but probably to me. Let's see. Can you talk a little about what your workshops could look like? Do they have to be 2 full days, or is there some flexibility there? Absolutely. I'll tell you what we do and sort of our sense of the outcomes that can come from that. Here in Rochester, actually outside of Rochester, and also in the Netherlands, and we've done this in Sweden, Norway, Italy, and a few other places. We done multi-day, 4-day and 5-day intensive. We get 30 to 50 physicians mostly, but other health professionals together for a live-in intensive. That's kind of the very intense side of things. What we have done, the next sort of level that we have done as we, from less intense, that we have had this following program that I'll describe with a number of healthcare institutions in Michigan, in New Jersey, in San Diego, and I'm missing, in Maine, I'm missing a few, where we do a 2-day intensive. And then we follow that up with a series of live hosted webinars where they're interactive. Unlike this one, you're just listening to me. There's dialogues. We put people into chat rooms and they share their narrative stories with each other as if they were in a live mindful practice session. So we call that the 4+2 or 2+4 program. We come to and travel quite a bit, Ron and myself and our other colleagues, and we are happy to do half-day, day-long programs, meeting with several groups of stakeholders if that's called for. And we've done that in many, many, many healthcare institutions, actually all over the world, probably every continent except for Antarctica we have been to, with a lot in the US and North America and Canada as well. And those can be very useful. I think, we're happy to come and do a grand rounds or something like that as well and share. However, we feel that it's such a passive learning experience that this kind of experience really requires, it's an interactive environment and experience, and to do something in 45 minutes or an hour and travel and spend all the resources environmentally and otherwise to speak to a group passively and not have them engage in dialogue with each other and actually use the mindful practice approach, for me is disappointing, because I know I could have more impact, and I think Ron would agree. So we're happy to discuss any other kinds of programs people are interested in, but I think thinking about something that is at least long enough where people can interact with each other, and that seems to have the most meaning. And the training that we do, that people come to us, actually is also designed. We have a teacher training program, so there is a pathway to become skilled as a facilitator and then take this back to your institution and work with the local institution and culture in the way that seems most appropriate. So I hope that answered the question. I think I tried to cover most of that. If there's any other questions or comments, I'm here for at least 7 or 8 more minutes if need be to talk. I'm just thinking if there's anything. I should say a few things. We in our training and in our program, I think we give people real tangible skills that they can use in their workday, in your workday, in my workday, to help sort of bring us to the present moment, to help us really focus in on what's important and to help us derive meaning out of our work. And I'll just mention one here that's so simple that I feel at least I've given something that you could actually use walking away from listening to this. It's a simple practice. We didn't make it up. It's called the STOP practice. And it's STOP is an acronym, STOP, and it just stands for stop, take a breath, observe what's going on, and then proceed. And I do this practice probably 20, 30, 40 times a day when I'm sitting back at my desk after I've left a patient's room, ready to bang something out into the keyboard, whether I'm crossing the threshold into seeing the next patient. Sometimes when I'm washing my hands, which actually now with infectious disease, I'm feeling is more and more important to actually pay attention to, a very important procedure that we do many times a day. So I use that as a way of just grounding myself. There are a few more questions, so let me open up. Okay, Marianne, can you give an example of mindfulness exercises that can be used by health professionals? Well, she must have known what I was about to say. That's one of them. That's called the STOP practice. Another practice kind of similar to that is called the 3-minute or 3-breath breathing space. The stop can be done in the course of a single breath. The 3-minute, if you will, breathing space comes from mindfulness-based cognitive therapy, which you might be familiar with. And it just, if you think of an hourglass, and the top of the hourglass being, bring your awareness to what's going on right now, Then you come into the middle and you take a few breaths. It can be 3 minutes of just conscious breathing. And then once you're done with a few breaths, you then say, oh, what's going on right now? So it's kind of a quick stop and then a focus on breathing awareness and then what's going on and how that changes. And we become very familiar with actually the changing nature of our own inner landscape as well as the external landscape. So that's another example. Next question, how can we establish an environment of mindfulness starting as early as medical school and residency for our trainees? Great question. Well, one of the ways is not just teaching. Sometimes we fall upon this idea that, we've got an idea and we have to teach it to the medical students. Actually, the courage to actually change ourselves. So our faculty and our culture in medicine, to the extent that we can have an impact on it through whatever is necessary, whatever skillful means we find to change that environment, will have a direct impact on the medical school and residency experiences. So I'm a very strong advocate. Yes, I think this is important for students to learn skills, for residents to learn skills that we teach in mindful practice. But it's my perspective that if I had limited resources and wanted to put them in a place that could have effect all the way down, that from staff on down to residents and students, I would say focus on staff and culture, the environment itself. And I think that's what I would recommend. Next question, let's see. How can I connect with Dr. Krasner to learn more about facilitator training opportunity? Well, you missed it kind of on one of the slides, but one is you can connect with Pia and ask her some questions about the program. We have a mindful practice webpage at the university in which you can send messages, but it's basically mindful practice, one long word, .urmc.edu, URMC, University of Rochester Medical Center.edu. So that is a way you can kind of find out, learn about our program, learn about our training program. But thank you for the question. Thank you for the interest. And I think that is it. If there's any more questions, and one of the things I was taught in when I was a resident was, you never should you leave a room and do this. As you're leaving the room, shaking your head like this and saying, do you have any more questions? So any more questions? If you have any more, please type them in, because I have about a minute left and I talk very quickly, as you have learned. But it's been a real pleasure. I'm excited for our work with Gold Foundation. I think their alignment with humanistic values in medicine just aligns so beautifully with our objectives with mindful practice, which is to really improve flourishing among health professionals. Please contact me, Ron Epstein, or Pia Miller at the Gold Foundation should you want to explore this further. Thank you very, very much for attending.